Hi, my name is Paul Urchard. I'm a pediatrician trained in hematology, oncology, and blood marrow transplantation with a special interest in MPS I. Today we're going to discuss a newborn screening and its implications in MPS I and its therapy. So MPS I, or Mucopolysaccharidosis type 1, is a rare lysosomal storage disorder. It's got a varied phenotype from the severe form, which is Hurler syndrome, to a much more attenuated form, which is previously called Shea syndrome.
Majority of patients diagnosed with MPS I have Hurler syndrome associated with null mutations and virtually no enzyme production. However, there are patients that have less severe disease or attenuated disease. This is initially termed as Shea syndrome, thought to be a different disease than Hurler syndrome, but it's just related to how much enzyme activity is present. Patients with Shea syndrome may live a quite normal life, although they have disease-related complications such as joint stiffness and decreased range of motion, may have growth problems as well. So newborn screening for MPS I has really begun in the last few years. It was added to the recommended uniform screening panel. The RUSP was done in 2016. The Secretary of Health and Human Services makes these recommendations based on severity of the disorders, the availability of effective therapy, and the screening test itself, the false positive, negative rates, costs associated with it, etc. The inheritance of MPS I is autosomal recessive. The parents are obligate carriers. They'd be expected to have one child of 4 that would be affected with the disease, one child of 4 that would be totally unaffected without either mutation from the parents, and 50% of siblings would be expected to be carriers. So the alpha L iduronidase gene, or the IDUA gene, is located on chromosome 4. The loss of function of the IDUA gene leads to the accumulation of glycosaminoglycans, sometimes referred to as storage material within the lysosome. If the enzyme activity is present, these glycosaminoglycans can be broken down, which are eliminated from the cell. However, if cells do not have IDUA activity, they accumulate this material within the lysosome, leading to the disease process. There's a significant correlation between the phenotypes and genotypes in MPS I. The data presented here is from the MPS I registry. There are several important points here. The patients with severe disease, or the patients with Hurler syndrome, tend to have severe mutations, nonsense or null mutations, whereas the patients that have attenuated disease generally have missense mutations that can affect a particular amino acid, for instance, and maybe have a small amount of functional activity. So the amount of enzyme activity that is present, it correlates to the severity of the disease. There's been a number of mutations within the IDUA gene that have been characterized. There are several that are primarily important in Hurler syndrome. W402X and Q70X are the most common. And the majority of patients that have Hurler syndrome either are homozygous for the W402X or the Q70X mutation, or heterozygous for both. But as you can see on this slide, there's a number of mutations that have been associated with severe disease, as well as mutations that are associated with less severe disease. But as one can imagine, there are a great many combinations that may be present. And even though in the majority of patients we can identify by genotype what the anticipated phenotype would be, this is not universally true. Establishing the diagnosis by newborn screening is generally done on the dry blood spot. Iduronidase activity can be tested on the dry blood spot. And if it's low, generally it's repeated, but if it consistently is low, that would result in additional testing. Enzyme activity is generally the first tier test in newborn screening, throughout the states. There are some abnormalities that can be associated with testing. There are pseudodeficiencies, for instance, in which case the artificial substrate used for the assay leads to an abnormal test, but is not clinically apparent. So one of the things we can do to distinguish this is to look at the accumulation of glycosaminoglycans. If there's a pseudodeficiency and it's a false positive test, one would expect glycosaminoglycan levels to be normal. However, if there's actual disease, glycosaminoglycans in the urine would be anticipated to be high. So this is commonly being used as a second-tier test to help establish whether disease is present or not. Another important question, of course, then is what phenotype would be apparent. And this may be clear on a physical exam and evaluation of the patient at birth. If they have significant signs and symptoms, you would expect to have severe disease, so the patient would have Hurler syndrome. However, these may not be apparent at birth, and rely on the genotypes to help us with that additional establishment of a phenotype. So again, the majority of times we can make that determination from the genotypes, but not universally. So in terms of testing, as people know, each state determines what they're going to test for and when they're going to do this. So even though in 2016 the recommendation was to add the MPS I to the recommended uniform screening panel, the majority of states still are not testing for MPS I. So some of the larger states currently are doing this, and more patients are being identified at birth, but a number of states have yet to put this on their own screening panels. As I mentioned, MPS I was added to the recommended uniform screening panel in 2016, at the same time as adrenoleukodystrophy, or ALD, and Pompe the year before. But there's no uniform way by which these states are rolling out the screening, as can be determined from this slide. Just provide an example of the situations that become apparent in terms of testing. This is information that was published by North Carolina. They had screened 62,734 samples. The initial testing identified 54 tests that were positive. These had been decreased to 19 by additional evaluation. And of those 19, one patient was shown to have severe MPS I. 13 had pseudodeficiencies, and the other 5 had mutations that were identified, but the significance of those and the phenotypes of those is yet unclear. The importance of a second-tier testing, which again may be glycosaminoglycans, became apparent from this report. Very briefly, in terms of pseudodeficiencies, a number of these have been described. The relative frequency is reasonably high, and some of these pseudodeficiencies are especially apparent in the Black population. So this is certainly a factor in doing newborn screening for MPS I. So in summary, MPS I is a rare autosomal recessive genetic condition. The alpha L-iduronidase gene is the important one in the terms of this disease. There's a variety of phenotypes that have been described, and in most cases, a correlation between the genotype and phenotype can be established, although there are circumstances where mutations are not necessarily indicative of phenotype. Newborn screening for MPS I was added to the recommended uniform screening panel in 2016. This is due to the severity of the disease and the now availability of testing and of therapy as well. It's critical to make the diagnosis as early as possible because early intervention makes a huge difference in not only potentially survival, but in establishing the best outcomes that are possible. There are currently effective treatments available, including enzyme therapy, which was approved in 2004, as well as bone marrow transplantation, which has been utilized for decades.